Hey, so welcome everybody today to the SCI Optimal Care webinar. I'm Shannon Rockall. I'm an occupational therapist. I work as a regional clinical liaison for Praxis Spinal Cord Institute, providing education sessions around the province on spinal cord injury to regional clinicians. I also work as an OT with Access community therapists with clients with spinal cord injury around the province. So James and I have been going around to the different hospitals, regional locations, and a lot of the conversations that we have with people, asking a lot of different questions about GF Strong, the services, how to refer, and a lot of questions that we're just not able to answer, obviously not being from within that system. So we thought this was a great opportunity to collaborate and to bring everybody together and to be able to hopefully answer some of those questions, provide some information, and also just want to say how thrilled we are to the to how popular this session was. We sent out the invite a week ago. We were expecting, maybe a dozen, a couple dozen, and we have over 200 people registered to participate in today's webinar, which is fantastic. So without further ado, we're going to get started. We've got a lot to get to throughout this hour. We've got some interactive polling, some presentations, and then some Q&A at the end. Before we get started, just want to acknowledge at Praxis Spinal Cord Institute, we're hosting from the land of the Syilx Okanagan Nation, and so privileged to be able to live, work, and play here. There are people joining from all over the province and potentially beyond. If you'd like to acknowledge the land that you're joining from, please do so in the chat. So what to expect for today? So like I said, we'll do a brief overview of the clinical workshops that Praxis have been hosting throughout the province. And then we have Tova Plashkes and Rachel Abel from GF Strong that are going to share some of the information about inpatient, outpatient education services and the process of transitioning to community and then accessing those services. So a couple different things. We will have a Q&A at the end. Hopefully we're trying to keep as much time as we can for that. And then we're going to establish some priority topics to continue these webinar series, see what you guys want and what the needs are. A couple little notes. So please refrain from using the raise hand function during the presentation. You'll have the opportunity to do that during the Q&A. If you do have questions that come up when Tova and Rachel are talking, please feel free to add your question in the chat box and we can address it during the Q&A. So we do have some interactive polling. So if you can take out your phones right now or be able to use the QR code, and if you load on Slido, we've got a couple questions before we get started because we want to find out who's actually here. Okay, so what area of the province are you joining from today? Kootenay's right up there. Nice. Excellent. Okay, so good distribution through Vancouver Island, Thompson, Okanagan, North, and Kootenays. And we got one from Caribou, which is fantastic. Interesting. These are all of the locations that we've done our SCI workshops in. So this is fantastic. We're going to, you can keep answering that, but we are going to move forward to the next question as well. So which discipline or role represents you most accurately? A lot of OT, PT, rehab assistant, researcher. Okay, so it's looking like we're a pretty solid allied health group. Okay, and moving forward to the next slide. So where along the continuum of care do you work? Recognizing that a lot of people work in a lot of places and a lot of capacities, particularly in the regional and remote communities where you do span the continuum of care with your services. So a lot of people from acute care, which is great. A lot of what we're going to be talking about too, not just today, but in the upcoming webinars is, of course, there's the initial injuries, right, that happen. But the reality of spinal cord injury is that people live a lifetime with their injuries and constantly, will have secondary complications of spinal cord injuries and need the readmissions. And the reality is that people with spinal cord injuries don't just hit along the continuum of care at one point. They continue to over different times of their life and as secondary complications arise. So who on the meeting has previously attended one or more of our regional clinical workshops? Excellent. Great to see that a lot of people that we've had the pleasure of meeting around the province have joined. Also, or sorry, I was reading that wrong. So some people have attended our workshops, but a lot of people haven't, and that's great. Thank you so much for showing interest and for showing up today. So with regards to the regional clinical workshop, so just a little bit of history on that. So James and I have known each other for about 10 years. I'm a clinician. James lives with spinal cord injury, and we would do these education services. So I worked at GF Strong for many years, and then had 4 kids in 4 years, and moved out to the Okanagan just so that I could afford to live here. And in doing so, I'm like, well, what am I going to do? All I know what to do is spinal cord injury. Recognizing as well that the regional clinicians don't necessarily have access to the specialized care, but needing that. So this was sort of a vision that James and I had many years ago, and then working for Praxis Spinal Cord Institute has allowed us to be able to do that. So we're going to show this video, which outlines a little bit of our workshops. This is one of the workshops that we did in Northern Health region last March.
Hello, I'm James Hektner, and I am with Praxis Spinal Cord Institute, and we are up in Prince George at UMBC for the Spinal Cord Injury 2-day workshop.
Our vision is that we want to live in a world without paralysis after spinal cord injury. Really, we want to translate knowledge into action. We actually want to do the research and then bring it into practicality and making sure that it does make a difference.
My role with Praxis is I'm the Regional Clinical Liaison together with James, and providing these workshops and being that clinical link from research into practice.
I chose to get involved in this because our clinicians have identified for a number of years that there has been a significant gap not only in in-person education opportunities, but in education opportunities focused around spinal cord injuries. And so we really wanted to help bridge that gap for our clinicians and provide this type of education. So reaching out to the Praxis team and Shannon and James was the best way to go about that.
So the reason why we do this is to help improve the confidence and knowledge in regional clinicians that are working with spinal cord injuries. We know that the majority of the resources are in centralized locations, primarily where the rehab facilities are, but not all of us actually live in those areas. We are regional, we are rural.
You know, I remember when I was 19, 20, 21 years old, I didn't have that voice. I couldn't really speak up for myself. And so now that's where I was trying to make, all right, let's make that roadmap, and hopefully I can make it smoother for any of the new generation that are coming up.
And that's why I'm so grateful to be here today, is to kind of be a story that can help break barriers in the future for when you are in front of someone possibly like myself, and how you could kind of facilitate making their quality of life better.
So everybody has a unique perspective, and it just seems to resonate when you're able to share some stories and experiences.
So yeah, I'm a C6-7 quadriplegic, 8 years post-injury. Stu Weimer from Kamloops, BC, C6, C7, quadriplegic, complete.
I was injured in a mountain bike accident about 18 and a half years ago.
So 8 years ago, I was in a motor vehicle accident just outside of Kamloops.
I think it's really great that you guys are all here today because you can see what people, you know, how after a recovery people are able to integrate and to adjust and to live really full, happy lives, because I think you don't always see that when you're seeing people just post-injury, right?
We do this because we're literally living with spinal cord injury every day. And to improve the knowledge and education for the clinicians that are working with us makes a difference.
My kids came to see me. My mom told me this. Makes me cry every time. And before they were allowed to see me, a nurse took them aside and told them, "This is your mom and she'll never walk again." And just what a cruel thing to say to a couple of kids who just want to see their mom, you know?
I had a pressure sore for 9 years. It's hard to deal with pressure sores, especially in a small town, you know, and being native, it makes it even harder. And I quit drinking in 2012, but every time I ended up in the hospital, they'd always ask me, when's the last time you had a drink, or something like that along those lines. Like I was an alcoholic, or I was there for the drugs, but I wasn't. I was there because I was sick, you know, and that,
And this is the personal impact.
And I'm happy to be here to talk about it, even though I'm crying. I'm not ashamed. You know, you guys are here and you're listening. And I want to learn and help you guys learn.
We're here to make a positive impact, and we need to hear the privileged position that we've been put in to make that difference, or to help prevent or to heal.
It really made me recognize that as a clinician, that you really do need to take that step and pause when working with individuals and work with them, not just work for them in a healthcare system, to not only improve your rapport and your relationship with the client, but the system overall.
Basically, your 5 bony prominences are completely offloaded.
All the little things that make the big differences, right?
If someone goes too far back, down, do you trust me? Do you trust me? He doesn't trust me. This is what would be helpful for you working as a clinician in Northern Health.
For me, it was around bowel, bladder, and sexual health, so things that I learned more about today.
It's pretty valuable, I think, to have some first-hand experiences for people that are actually living with spinal cord injuries or whatever population it may be. A lot of the times it's all theoretical, so you don't get chances to really interview or get first-hand counts.
They are the experts in what having a spinal cord injury means to them, and they have learned how to interact with their world and what works for them in a way that I think able-bodied people will just never experience.
So we're very passionate, we're very dedicated, because it impacts us.
I would advocate for all physios, OTs, allied health, nursing to take this education and to be a part of this, because it's been an amazing experience.
I love watching that. I love watching that video. It just really shows the impact. Hello, my name is James Hektner. I am a Regional Community Liaison for Praxis Spinal Cord Institute. I reside down here in Kelowna. I'm also president of Accessible Okanagan, which is a local community organization here that kind of stretches from Kamloops down to Osoyoos, and of course a few members scattered around BC and beyond. We utilize our organization obviously quite heavily to bring in the Plex perspective and experiences during our workshops as well. I had a car accident, almost 28 years ago now, actually out in rural Alberta in Sundre, north of Calgary. And had a T6 Asia A spinal cord injury. So of course I went through the rehab process there in Alberta at the Foothills Hospital. It was a 3-month process going through rehab and such. Of course, one of the most difficult times of my life. But about 10 years later, I actually had a shoulder surgery that I had down in Vancouver, and actually also um, had the opportunity to utilize the services at GF Strong as well. So 2 different rehab centers, and being able to obviously get the assistance that I needed. But both places unbelievable, giving you the education of and such that you need, and obviously the rehab that you need. I do want to mention though, like in this particular webinar, I mean, I haven't seen anything like this before. So being able to bring in the connections from the clinicians all over the province like you did, and have 200 people registered for it, is pretty amazing. So hopefully, we can utilize this and expand on it and use it as a, kind of a discussion platform or a knowledge translational opportunity to obviously help our regional clinicians, and of course, ultimately the spinal cord people living with spinal cord injuries around the province. So without further ado, I really want to pass this over to Rachel and Tova, and be able to provide some insights on GF Strong and referral process. Thank you.
Thanks, James, and can't say how excited I am to be here today and meet some people that have sent me many referrals and that we've gone back and forth on, and recognize many names from clinicians that I've worked with in the past. And yeah, just such a pleasure to be here today with you. Just putting up our contact information. I am, some of you may know Nigel Kam, who was previously in this position. I, for many years, have worked in spinal cord injury all the way from ICU out to outpatient care. And then just recently, I moved into this position where I do both inpatient and outpatient admissions for spine. And Rachel is our client educator, so she'll talk a little bit about what her role is in our inpatient program and a little bit later. And then we can talk more about how you get in touch with both of us and how we can help as we go through here. So I understood there were some questions about what are the referrals that GF Strong gets and how many people and that kind of thing. So I pulled up some statistics from last fiscal year. So we had 220 referrals and consult requests. The majority of those come out of VGH, but those can be people who need our care, but also sometimes it's the physiatrist just managing care at VGH. 106 people went to our inpatient SCI program, and 6 went to our neuromusculoskeletal program, and generally they take incomplete injuries when our spine program is full. And then we also have a transitional rehab unit, so for people who are medically stable but not ready for 2 to 3 hours of therapy a day, which is what we ask for our spine program. I often get asked, are you even allowed to refer to our inpatient program? The answer to that is yes. We've taken quite a few inpatients from around the province and from some of you over the last number of months that I've been in this job. Obviously, we can't take everyone as much as we'd like to. I can talk at length about some of the pressures, especially as the population's been aging and long length of stays and all of those things for hours, but I won't do that today. How do you refer? Call me and I can help you piece through all the bits that need to come. The paperwork I need is available. Just Google the GF Strong inpatient referral form. You can fax it, you can email it, but I often recommend that you give me a call just so I can help you piece through what the sort of salient points are, so you don't have to fax me a 600-page chart or anything, and we can sort it out together. What is our outpatient program? So I was going to include, we had our Christmas party last night, a picture of all of us. Didn't quite get to that this morning. We have physiatrists that work generally through the Blessing SCI clinic, which is near VGH. And that's also, it's a multidisciplinary clinic out of which are spine surgeons, physiatry, plastics for wound care, urology, so a sort of area where many of our clinicians working with SCI and spine injuries work, which is really great. And we work closely with them. Our team here at GF, the spinal cord outpatient team, includes OT, PT, nursing, social work, rec therapy, dietitian. We also have psychology and those sorts of things, but who they can take is somewhat limited in some of the due to geography and those sorts of things. I can talk more about that, but generally, again, just call me and we can look through it. You'll hear more from Rachel in a moment, who does our client education. We also have this, we can access our specialty services like assistive technology, driver's rehab, orthotics, vocational counseling, those sorts of things. We do take in-person people who need to come down and see us from out of health authority, but we don't have housing. But we often can support trying to sort that out, something local, and we have a whole booklet about that for patients or families. And how do you refer? Again, just Google the form. I always do that so that if we end up changing the form someday, your permalink doesn't disintegrate. So it's the first thing that comes up when you Google the GF Strong outpatient referral form. Call me if you have questions. We will require a team in the home community, whether that's in an acute care hospital or if they're in community, their home health OT, to work with. So because we work generally on a consultative basis, we try to get to our high priority referrals within a month. Sometimes it takes a bit longer depending on if we need to see them in person, and we're trying to organize different disciplines to see them at the same time, those sorts of things. And then our medium priority, so high priority is things like wounds, or major change in state of function sorts of things. Medium priority would be most of your seating referrals and general injury, shoulder injuries, those sorts of things. And then our low priority is more for trying a new piece of equipment or something that we don't feel is time sensitive. And then consultative support is somewhat similar. Try and give me a call. Often I'm going to ask for a referral. So a good example is Krista on the island has some of her clinicians have a gentleman who's struggling. They sort of gave me the rundown on what the case was, and I sort of said, okay, it seems like we could really use physiatry, and then let's start with a clinician to give you a call and figure out what the next steps might be. And I really like doing it that way so that we're not putting them on a list if the priority's wrong, we're not sure what's going on. So often it's myself or one of the other clinicians will give you as the receiving clinician a call to try and triage and sort out a plan and figure out if there are more urgent things or referrals to urology and those sorts of things that can take time. Let's get that done first and then sort of sort out a plan as we go. Keeping in mind, of course, we want to make sure that people who don't go through that route still get seen in the correct order. So it's a bit of start with figuring out a plan and then move on to next steps and being seen in order with the other clients. I will say this is still in its beginning stages, but there is a talk with the Rick Hansen Foundation at looking at an SCI navigator. So that would be a contact, somewhat what I'm doing now. To be totally honest, I don't always have the time to do it, but I do it anyway because I care so deeply about spinal cord injury and about our clients all over the province of how do I manage this? How do I get this person in the right, to the right, place, to the right clinician, to the right, how do I help them the best? So there's work ongoing to have a clinician in that role, specifically around, I think, the people that you are seeing who are chronic SCI, who are having trouble managing for one reason or another. We know that aging with a spinal cord injury it's a tough business, and trying to make sure that those folks don't, have a place to turn to, and it's a little bit more direct pathway. but I don't know the details of that yet. I'm just very excited. So in terms of how many referrals we get, so again, on the same time period, April of 2023 to March of 2024, we had 336 referrals. Some were rejected, and I'll talk more about why that might have been. Some were only seen by a physiatrist, and then more than half were saw our physios and OTs, and then a kind of smattering of other things. And then some of our services, as I said before, limit their referrals in one way or another based on out of health authority or how many, if they're seeing other clinicians, if there's other services available. So I'll say that our goal is always to try and ask that local services are used first. And then if there's no one else that can serve them, and it's SCI specific goals, that's really where we'd like to step in for our out of health authority clients. So I'll give you some examples. So this is one I got recently. He's a young man from Fraser Health. He had a long spinal fusion and juvenile rheumatoid arthritis. He had complex seating needs, community access needs, and work on transfers. The challenge was he did not have a spinal cord injury. So for that reason, I had to decline the referral. This was a 57-year-old from the island, remote, incomplete spinal cord injury, who had some bowel and bladder challenges and some balance issues. And what we ended up doing after talking with the client and with the referring provider was we said, okay, the physio goals don't seem SCI specific enough for us to accept. We ask that you refer to someone more locally, and then but we did accept the referral for bowel and bladder management to talk to our outpatient nurse. 42-year-old from Interior had a mild cauda equina injury. The bowel and bladder was intact, but had foot drop. Declined this one because we felt, again, it just wasn't SCI specific enough and could be managed with local services. This one was a para 28-year-old from Interior Health with a new stage 4 pressure injury, needed complex seating, and the home health OT was feeling that this was really a complex issue and really felt like the wound needed to be followed, the seating, all those sorts of things. So what we did was accepted that referral after talking to the client and realizing that coming down here for seating, there really wasn't another option. The client was going to be coming down to see our wound clinic anyway. There wasn't good support in the home community, and they also were known to our team previously, so it seemed like a good fit. Those ones are tough ones for us, just knowing that, can we accept every person who has a spinal cord injury who needs seating, and still maintain, more other goals, space for other goals within our program. Is really challenging because our FTE is not very big, but in the end for this one, we wanted to make sure that the seating goals were managed so that we would have success with if and when this client needed a flap surgery. And then a lot of, especially in the new ICBC format, I'm declining a lot of referrals who have access to enhanced benefits. I'm not saying we never accept this, but I'm saying that they should be trying to use those benefits first. And if those clinicians need help or the person or that sort of system is not working, then we could consider it. I don't like to just sort of auto decline because I know it's challenging to manage those things, and especially when not every ICBC hired clinician is going to know a lot about spinal cord injury. We try not to decline it but we want them to try. And then if it's really like we can't find another way to manage this, then sometimes I'll accept it because things are going haywire, and we just, if we make them keep trying to do it themselves, things are going to keep going haywire, and the client's going to suffer.
Okay, I'm going to jump in here. Thanks, Tova. And I just want to say, to add on to Tova, if your client gets rejected or declined, don't see that as discouragement to not refer the next client, or if you're unclear why, definitely contact Tova. She's very open to discussing it. And also our admission requirements and timelines and wait times, they're constantly changing, as you all probably know in your health authority. So sometimes things are moving targets, and we do our best to adjust with the system. So I'm Rachel, and I'm here as I'm one of the educators here, one of two positions, and I'm specifically assigned to the spine program for program development. And then I'm an OT by background, but this role is interdisciplinary educator position. So I support all sorts of things, and specifically the spine program. So if you guys ever have questions about resources or next steps or what to do with your client, I would be a good person to contact. Sometimes people just contact myself and Tova simultaneously, which is also fine. So I wanted to give you guys a sense of our SCI inpatient program. So GF Strong has 4 units technically now. We have a brain injury, neuromusculoskeletal injury unit, and then a spinal cord injury unit. And then we also have a transitional rehab unit, and that was brought in around COVID or post-COVID to transition clients here a bit faster who aren't quite ready for intensive rehab, but they can come start some slow stream rehab and then transition to one of our more intensive rehab spaces. So for our spine unit, we have 22 beds, and we have a mix of spinal cord injuries, central cords, flaps, anyone who presents like tetraplegics. And we also are one of 2 centers, is that right, Tova? We're one of the few centers in Canada who does take ventilated clients, but we have a limit on how many of those clients we can take. We can take 4 max, but usually that's too much anyways. Some of our clients will go to the NMS unit. So if you have a client coming from there, they could still have a spinal cord injury. Our length of stay varies, and if your clients are ever getting transitioned from your health authority to ours, I would never give them a timeline, but just for your guys' sake, our paras are roughly 8 to 10 weeks and tetras 12 to 16, and those can vary up or down depending on goals. I won't run through all of our disciplines, but they're listed there. So we have a really good multidisciplinary team who works together, and you guys might have been in communication with some of them if they're discharging patients to you. And we also have a lot of specialized services by referral, like driver's rehab, sexual health, spiritual care, and just for everybody else, there's a typo there, but our assistive technology service is a provincial service, so anyone can get referred to them. We also have our SCIBC office in-house, which is really nice for peer support, and they have a website and they can connect people with all over the province, so it's really good to connect with them if you need some peer support or groups in the community. And typically, therapy runs Monday to Friday, 3 to 5 times a week, depending on the need. And there's very minimal therapy on the weekend, just a little bit by physio priorities. Just so you guys know, it's good to know, but we do send people home with what's called a My Discharge plan, which has all their follow-up and community teams. So some of your names could be on there. And then we do send an interdisciplinary report, which we found that sometimes gets lost in the system a bit. So you can always contact those therapists and ask, hey, can I get the interdisciplinary report? And that should tell kind of the status update and ongoing goals. Let's go to the next slide. So I run the client and family education. So I organize it, and it's run by all of our clinicians. They teach all these different topics that I've listed. They run from Tuesday to Thursday, Tuesdays and Thursdays from 12:45 to 1:45. And any of your clients who do not get to come to GF, if they are interested in attending the client education, contact me and we can join them in via Zoom. So this is for clients, their families, and you as therapists can join alongside your clients. Unfortunately, we know there's a need, but we cannot have, it's not for clinician education, because as you see, there was over 200 people who responded to this, and just for patient confidentiality, we don't have clinicians there, but you're welcome to join alongside your clients. And there's a ton of different topics, which I won't go through. And I do have an email distribution list where I send a calendar out monthly. And so if you want to be on that calendar distribution list, you can just shoot me an email after this. And just because we're just doing an intro today, I just wanted to give you all some resources that you can look through, and we can go through these more in depth at another time, but these are a lot of resources that we give our clients, and my contact is on there. And then specifically the third bullet there, that's our website, Living with SCI, which has a lot of really, really good information. So you can take a peek at that. But these are really good resources for your clients if you're ever looking for something, or just for yourself for education. So if you have any more questions about that, or if you're looking for something more specific, you can just email me. I think I'm out of time, right?
Awesome. Thanks, Rachel.
Yeah.
Thanks, Tova. So I'm assuming that some people have some questions for you, which is great. I just thought before we get into that, it'd be good to know. So James and I have the privilege of going around to the regional health authorities and to a lot of the smaller hospitals throughout the province. And we often hear some of the challenges that regional clinicians have in meeting the needs of their clients with spinal cord injuries, because we don't have access to, the specialized services. Oftentimes clients are not able to travel, either financially, or they can't, their care provider can't travel with them. There's a lot of barriers to people being able to access specialized care in the Lower Mainland when they live in rural and remote areas. So yeah, if you guys can we would love to hear from your perspective as a regional clinician providing care for individuals with SCI. Can you describe in 1 to 2 words what your experience is like? Overwhelming, for sure. Challenging, scary, uphill battle, minimal support, insufficient resources, frustrating, inequitable. I have so many questions about all these. Want to have conversations.
If it makes anyone feel any better or worse, that is also a lot of the words that I think our staff would use.
Absolutely. Insufficient resources. Okay, want more education. Okay, that's good. And that's why we're here today, right? And planning on continuing these webinars. Lack of resources. Yeah, no, that's a really good point, Tova, about, for me, having worked both inpatient at GF Strong for many years, and then now being in the community in a regional area, all with spinal cord injury. Yeah, it's some different issues, but the challenges still are the same for sure. As far as feeling overwhelmed and intimidated, lack of resources, lack of time, right? What we're able to, we're clinicians, we've had the training, we know what to do, or we know at least maybe what our clients should, could do, but can we actually do that with the resources that we have? So this is fantastic. Thank you so much for providing that input. We are going to take all this information that you guys are putting into Slido, we're going to take it out, and we're actually going to use it for upcoming workshops. So speaking about upcoming workshops, actually, you know what? We're going to hold off on this poll. Maybe, James, if you want to just stop sharing your screen, and then why don't we have our people to ask questions? Now we can open it up to anybody who's interested in asking questions for Tova or Rachel or possibly James, right?
Yeah, so if you have a question, feel free to raise your hand and we can unmute you. And then you can ask your question, or if you don't want to talk, you can also ask it in the chat.
And are people able to raise their hands? We're a group of clinicians and educators here. We are not technology experts. Gotta say, it's been pretty glitch free so far. But...
Oh, they can't unmute.
There we go.
Found a glitch.
Okay,
Perfect.
Sydney,
awesome. Yeah, I'm on it. Mics are disabled. Yes. Can you guys, do you have the raise the hand function? I'll be able to unmute you that way. Except my screen's frozen. 1 second.
There's a question about, do you link to the resources? Can we ask the Praxis folks to send out Rachel's resources slide at the end here? And then maybe also we can include I guess the links to I think just Google the referral forms. That way, if I change them, you don't lose them.
Okay, good call. Yeah, absolutely. We can send out that resource list, which is fantastic.
Right, awesome. Krista, I believe you should be able to use your mic now. I am muted. I allowed you to have access to your mic.
Thank you, but we don't actually have a question. We just can't actually type in the chat.
I can't either. I don't know.
I see one of the questions there. I only put a few resources, so feel free to contact me if there's something more specific that you're looking for, but the Living with SCI is like a really good one. And then I was just going to answer the question about remote injuries facing aging process. Yes, we see that so much. We sometimes get those older injuries or flap clients as inpatients, but a lot of that is outpatients. And that's what Tova and I are really trying to support the community with, because they're even more complex in a lot of ways. And they know themselves well, and they know what they like, and they know what they want. And it's complicated. And so we kind of want to have people on our radar so we can support and provide consultation. And we don't necessarily have the full capacity to do that right now, but as Tova was alluding to, there are lots of discussions in the background with Vancouver Coastal Health and GF Strong about how we can better support people. So it's good to refer and then try to get consultative support so we can help you with those aging clients. And there's lots of aging resources if you're wondering about that injury as well. But if you don't refer, we don't know that there's a need. So keep doing that. Just keep Tova with a job.
Yeah. Or more of a job. I'll just say also that SCIBC runs an aging with SCI community group where I've come to talk to them about various things. So they do like a monthly guest speaker on how to age well. And yeah, James just posted the Skyer website as well, which has some really lovely resources. I would say our outpatient team, more than half of what we're dealing with is people with aging, changing seating needs, crappy shoulders. And then occasionally we even see people who come to our inpatient program where they've been out in the world and doing really well, and then you get a change in function. So it's a huge part of our work. I think it's the good news, bad news. We're much better at taking care of spinal cord injury than we were 20 or 30 years ago. But that means that now you got to deal with aging plus spinal cord injury. And, I think of this concept of frailty a lot, which is just like everything that makes you sick makes you sicker. So it's something that I know a lot of the clients who stick in my brain. What do the kids say? Live rent free in my head. Are the ones who are dealing with that. So a huge part of our caseload. So yes, we want to talk about those people for sure.
Awesome. I just gave everybody the ability to unmute themselves. So I think Shannon was going to say the same thing. Sorry, Shannon. So no. Susanna, I see you have your hand up. So please let us know your question.
I just was so excited watching that video. I want to be there right now. So I'm over on the island. I think there's a bunch of us online from the island. When might you be coming our way?
So Susanna, you're in Duncan, right?
Yeah.
Okay.
But I would go to Nanaimo or Victoria. I know those are bigger centers, and obviously it'd be good to have a big group.
I know. Yeah, we were just up in Courtenay Comox, and we did a session there. We will be in Victoria in February. So the only limitation to that, it is open to South and Central Island. The only limitation, of course, is space. So not sure how much space we'll have. It depends on the room, but let's maybe connect and see because, and what discipline are you?
OT.
OT, sweet.
I'm away after February 20th. So. And one other thing that comes to mind, because it's always such a great resource having GF, and but one thing I've noticed being in community is sometimes people will come over to us that have done all their inpatients, done their seating stuff, and they will have had trials, but not with a vendor that we have. And I'm just wondering if there's any way we can get involved much sooner in that process, where we can work collaboratively with the therapists that are seeing the people people as inpatients to say, these are the vendors we work with, and just kind of get to know that client ahead of time, go maybe see their house with their family or something and provide you guys with information, just to get involved earlier to help with that process.
Yeah, that really like is what the therapist should be doing, making sure they have local vendors. And so if you ever get that problem, it's good to give us that feedback. But the vendors seem to be often changing, and also we find sometimes that community partners have different opinions on that as well, so it can be challenging. But please let us give us that feedback, because that's what they should definitely be doing with the vendor process,
Right.
because we know that they spend their life in the community.
Right.
So,
yeah. Thank you.
Yeah. And there was just a couple of things. I think one of our topics for education for future will be managing and what you should be managing for spinal cord injuries in acute care, because that seems to be coming up, someone's just in there and what should we be focusing on, or what are key things to focus on. So we might do a session on that, because that seems to come up a lot. And then I noticed some nursing questions came up, and nursing is very challenging, even in our own center. We do have an outpatient nurse position. That person's been off for a while, but we have two people kind of sharing that. And so if your nurses need consultation, because again, the nursing is very specific for spinal cord injury, this is where, again, you can get a referral just for nursing to support the bowel and bladder piece, because a lot of people leave here and then they change and their bowel and bladder changes so much. So we like them to have that connection. And we do have inpatient nursing educators that are sort of equivalent to my position as well. But it's definitely a challenge. And rehab nursing, we're finding, is sort of just dwindling away as well. The program is there's no longer a certification for that anymore. So it's very challenging. So maybe, I know there are some asks. There was an ask from a nurse in Fraser Health about a rehab nursing group, and we might look into that. Just came up today, and we might look into how we can start a rehab nursing group to support the nurses.
I just wanted to say that, my vision for this is that really, I can't think enough that James and Shannon are building a sort of I imagine it as our foundation of knowledge. And then the goal for us at GF is to give you that just-in-time support that you might need if you're only seeing one spinal cord injury a year, and you might have, 2 years from now when you've forgotten everything we tell you, call us, and hopefully we can, because sometimes it's just a quick phone call. Other times it's a more in-depth, and especially with nursing, we know how challenging it is, and our nurses really do want to support teams, especially because I find when you come into acute care, their bowel and bladder changes. So yeah, just a note about that.
So, Grant Houston, that's a name I haven't heard in a while.
And I just want to acknowledge that the complexity of this group, this population, is very intense. I've trained a lot of therapists over the time I've worked on all the units at GF Strong, and this seems to be the scariest for most clinicians. So we are aware that all those words that you guys were describing earlier is very normal, and it can take a long time to get comfortable with this population, but also it's really rewarding and fun. It's my favorite and my passion. So I know it's hard when you don't see this population all the time, but we're trying to, we recognize the complexity, and also just that there is a increasing complexity. People are living longer, more complications. People are getting injured at an older age. There's more life-saving technologies, but there really isn't the system in place to support them. So this is part of why we're starting this. And I also recognize that this is just virtual, and hands-on clinical support is really valuable, because that's how I learned so much, is that hands-on, and maybe this will evolve over time into something else, but just keep trying and practicing and working together, and we'll do our best to help all of you guys.
Hi, can you hear me?
Sure can.
This is Grant. Speaking of age,
Grant.
Tova, does the inpatient programs have an age cutoff?
Great question. No, it does not. And I would tell you that my clinicians are wondering right now, everything varies. So right now we have quite an older group. It's not so much about age, it's where is the discharge plan. So I think what's changed a lot in the last little while is that one of our acceptance criteria is that the plan, although it doesn't always work, is to go home. If you're headed towards long-term care, that is, and I'll say something else in a second, generally speaking, an exclusion criteria. The exceptions being when somebody's going to a very small community that can't support them, and I do a ton of work in the background to figure that out. Sometimes we will take, because we don't want people to go to small communities who have really complex needs, even if they are going to long-term care. But generally speaking these days, because our wait list is pretty crazy, unfortunately, we are declining clients who are headed towards long-term care.
That's understandable. We're just seeing so many people that are older but quite young for their age.
Yeah, for sure. So we really
a spinal cord injury at
exactly. I mean, it's just been old age. Yeah, it's been an education being in this job, and I would say it's the group that gives me the most distress, moral distress, is the older new injury, and how do we, especially with lack of funding, and changing care needs right after their injury, it's a huge issue, and making sure we're giving them the true understanding of what their quality of life is going to be, how much it's going to take out of their families, and we're in the midst of a home care crisis, as all of you know. So it's a huge part of my world. I want to talk about rehab nursing a little bit because, as Rachel says, super important. Ashley Thompson will be back in the new year sometime. Right now, Rachel and Maria are filling in. They have a phone number that you can call. Any client can call. You don't need a referral. You can call and they will call you back. Or you can ask, if you have a client you want them to call, put in a referral. And even now, they're still reasonably quick at picking people up. Especially if you're like, this person's in trouble, can you help? And they can be in acute care. That's fine. We're happy to help, and we're happy to do clinical consultation. It's just right now the sporadic nature of them covering, because they both work inpatients. So it's a bit challenging right now, but we're hopeful to have Ashley back full time next year.
James, did you want to pull up the Slido question again? I'm seeing quite a few of these questions coming up in the chat box, and we will, if we haven't answered them already, we will get back to you on some details, some of the locations that we're looking at for workshops, and again, the rehab nursing, like what Tova just said. These are all needs that we identify, and people want information. We also, James and I, we can help facilitate information, right? Sharing of knowledge and resources, and connecting you with people. So always feel free to reach out to James and or I on the resources or any of these specific questions that you have. So James, or Slido question.
No, it's showing.
It's not showing.
It's not.
No, it's not. I'm not sure if the Slido question is still up there. So just to go over if you guys can still access it from when it was up there before. But it's basically this webinar series that we're doing right now. Here we go. So this question is about, we'd like to continue these series, collaborating with GF Strong and other specialty, resources around the province. How often do you want them? Okay, it's looking like monthly is the preference, and of course, we will send out invites, and if it's a topic that of interest to you, then you can always join, and if not, then that's fine as well. It would be, yes, we are going to record them. We are recording this one, and we can always send them out as well to make sure that the information isn't lost. I would love to go back to that other question, James, on the topic, on the areas of of interest for the topic areas, because there are so many areas that we could talk about with regards to spinal cord injury. Becomes overwhelming. And there we go. Here's the one. So to indicate, if you guys can indicate the spinal cord injury topics that you would be interested in learning about, that will help us guide future webinars, knowing what the priority is. And okay, so spasticity and contracture management, transferring techniques.
And I don't know if anybody can comment. Are you thinking transferring like manual transfers, or also about like slings and all kinds of wacky equipment we use? I don't know if anybody has a thought about that.
Patient handling too, if that would be in that. Oftentimes when we do our hands-on workshop with the when we go out to the different areas, we sort of like to cover it all, and also ask the people patient handling hands-on. Okay. Pain, that is so common. Hey, James, are you able to, I feel there's more options on this. Are you able to scroll up, or is this all that we can see for Slido? Because there's about 20 options. Oh. Okay, there we go. So what I'm seeing from this, given the numbers 54, 53, 50, on, there is a lot of you that want more information, and on a lot of these areas. What is sexual health the lowest number there, James, that you can see? Is that
what it looks like?
Yep. Okay. Okay, perfect. So this is great. Again, we're going to take this information out and pull it together. Okay, well, there's more. To be able to, okay, yeah, you so good. I'm glad, Kira, that you guys can see the options on your phone, because a bit limited on the screen here. Yeah, this will help guide it for sure. We will be sending out, Colleen will be sending out emails and resources to all of the attendees. Yeah. And just to answer that question with regards to workshops, that would be for James and I. Through Praxis, we provide those workshops. And of course, GF Strong provides the inpatient and outpatient specialized services throughout the province for people with spinal cord injuries. Thank you, Lisa, for your comment. Carolyn, that's great. If there are any other questions, we've got 1 minute left. And if not, then we will resume this in the new year for our next webinar.
Question from Grant.
Go for it, Grant.
I just had one other question. About how many people get on your inpatient service from outside your health authority?
More than I thought. I think I've taken, since I started the job in May, I've probably taken about 6 from Fraser, 2 from Interior Health, 2 from the island. So it's maybe like, if I had to guess, it'd be like 10%, not at least somewhat coming through. Like, not, these people might live elsewhere, but that's, sorry, let me rephrase. Coming directly from another health authority. If they're going through Vancouver General, I consider that a different thing. So, but if they went straight from Royal Inland, or straight from Community in Nanaimo, or straight from, I think some of you are nodding your heads at the clients I've taken recently, but yes, it does happen. And I think that's the kind of thing we've talked about. I don't want to say too much, but it's a huge issue. And we do want to look at those patients who need inpatients that we can't serve from an outpatient basis.
And we also, I meant to say this, but we also take clients from the Yukon.
Right.
Thank you for doing that.
Yeah, we know they're out there struggling, so we want to make sure we can help. But the challenge for me is that I've got people waiting such a long time for a bed, yeah, it's not optimal care. We were a bit uncomfortable with the title optimal care, by the way. That's where we're trying to go. I don't think that's where we are, because we know we want to jump on people, especially who have such potential for return of function, getting therapy sooner. But a lot of the times they're waiting for us, which kind of is unfortunate.
Thank you, everyone, for your time. Thanks for joining, and looking forward to more of these to come.
Thank you very much. Thanks, Rachel, Tova.
Bye.